Good afternoon, everyone, and thank you for joining us today. The National Association for Healthcare Quality defines excellence in the ever-evolving, fast-moving profession of healthcare quality. We identify and validate the body of knowledge required to serve as a healthcare quality professional and provide individuals the tools required to meet that standard. Our members execute quality functions across the continuum of care. They are members of quality departments, direct and ancillary care providers, and healthcare administrators. NICU equips professionals with the tools they need to succeed at all levels, from the new quality specialists to seasoned executives. For those new to quality or those who have simply require a basic understanding of the healthcare quality function, we offer a Healthcare Quality Principles program. For those that are highly committed to the quality profession, NICU offers the only accredited certification in healthcare quality, the Certified Professional in Healthcare Quality, or the CPHQ. The CPHQ designation is held by more than 9,000 healthcare quality professionals who are universally recognized, qualified in their work. For advanced and master practitioners, NICU developed the Q Essentials, the essential competencies for the healthcare quality profession. The Q Essentials articulate the competencies required for high-functioning professionals in quality roles of today and tomorrow. These programs, along with our peer-to-peer networking and member engagement platforms, provide healthcare quality professionals the end-to-end support they need to be successful in a fast-changing healthcare environment. Beyond membership, we collaborate with institutions, corporations, and other organizations to advance the field of healthcare quality. In order to bring our members leading-edge content on what is going to go on in the field today, we collaborate with private sector corporations to deliver this information. That is why today we are bringing you this complimentary webinar in collaboration with Nuance, one of our corporate supporters of the regulatory and accreditation Q Essentials area. The webinar today will focus on the topic of the new face of sepsis. Are you ready for July 1? This complimentary webinar, sponsored by Nuance, is aligned with NICU's Q Essential Competency Regulatory and Accreditation. The 6 competencies of the Q Essentials define the expanding and emerging healthcare quality professional roles of today and tomorrow. Today's content is just a glimpse into the wide array of content NICU and our supporters offer to members. To obtain more information regarding Q Essentials, visit www.nahq.org for additional resources to support your career. Leading our discussion today is Deborah Larkin-Carney. Debbie is the Corporate Vice President for Quality at RWJ Barnabas Health, where she is responsible for the ongoing development and involvement of RWJ Barnabas Health quality and safety programs. This includes providing leadership, direction, and oversight of the Performance Improvement Department activities at an affiliate hospitals and practices, and the development of increased capacity to execute performance improvement across the health system. She has over 30 years of experience in healthcare. Welcome, Debbie. I'm now going to turn it over to you.
Great. Thank you so much, and thank you, everyone, for attending this program today. It is probably one of the most challenging measures that we have today that has come out of CMS. So we'll go ahead and talk about sepsis and move forward. Maybe. There we go. So are you ready for July 1st? Are you ready for sepsis is the question. So here we have our agenda that we're going to be covering today is not only what is new for July, but also what is the best practices, how can we move along the treatment of sepsis. So the sepsis initiative, so why is sepsis so very important? Well, for us, it started with quality doing their reviews, for mortality reviews, what was the major cause of death, and that for us was sepsis, as it is across the country. We also had the Surviving Sepsis campaign, which is a national campaign we're all familiar with. And for us in New York, there was a Rory's regulation that started in 2012 where unfortunately a 15-year-old boy was actually died of sepsis, of unrecognized sepsis, and it became then a regulation that every hospital in New York has to have a sepsis program, very well regulated. in response to that, New Jersey Hospital Association started a collaborative saying, this is an important care issue, and we really need to do that. And our goal in New Jersey is to reduce the rates by 20%. And that started, the collaborative started last year, and we are now at that. And then, of course, CMS did their sepsis bundle, which has proven to be challenging for everyone. So there is some changes in July of 2016 that everyone has been, what is it and what's going on? The challenges of, unfortunately, of the CMS bundle, of the all or nothing bundle, really has been a monumental task to do all the abstractions, and I think all of us feel the pain. And the information that's available with the specifications manual and the questions from QNet has certainly been contradictory. So I think that status will continue throughout the year, but as we grow, and those of you who've been around long enough know the same thing happened with the skip measures, so it's probably not a surprise, but the sepsis bundle has particularly been challenging. So we're going to review some of those changes that are happening as of July 1st. One of the things is administrative contraindication care, and that's the refusal of blood draws, IV fluids, and they've now added vasopressors. So they have actually split this into two elements of severe sepsis and septic shock. So the time windows is for severe sepsis of 3 hours and septic shock of 6 hours that you have to have documentation of that administrative contraindication to care. One of the things that's been popping up on the QNet or the listserv for sepsis has been most nurses are the ones who document it. Why does it have to be a physician documentation? I think that's going to eventually be cleared up as well. So there's that timing. The algorithm actually is looking at discharge, so there's going to be a discharge question of timing. They are going to include all patients now whether they're transferred, expired, or left AMA, not just expired. But it's going to use that 3-hour window to exclude severe sepsis. So if you have a patient that was transferred out after the 3-hour window and that repeat lactate was not done, you would still may fail for that. So the discharge time will be required to answer on nearly all patients, so that's a part of that algorithm. And then what in the world of programming and the world of the algorithm, it's called the severe sepsis counter has been removed. And what the algorithm did before is asked the questions for all of those components of the bundles. And it would ask you for each one of those questions, and then it would just count whether you passed or failed, and in the end of the algorithm, it would say pass or failed. What they have changed now is if you use skip logic, meaning you allow for graying out depending on what the algorithm, when the algorithm kicks you out as being failed, they're now doing that. So if you go through and you failed your initial lactate level, if your vendor does skip logic, then the other questions would not be asked for that. So wherever you started failing, then the skip logic would work. My thought and what we're doing here at RWJ, Barnabas Health, is that we are turning off the skip logic, and for this reason. If I fail at initial lactate, but I'm also failing 2 other ones, I will never know that because I'm not abstracting it. So I need to know where all my failure points are so I can work on all my failures and not just one at a time, because it would take too long to do that, to get that level of improvement that is needed. So this is why I would say that you need to continue not to use skip logic, And also larger sample size. I've noted some hospitals are only doing 5 cases in a month. That in no way is going to give you the idea how you're doing with sepsis. And on top of that, with your denominator being so low, if you have one failure, you're only going to hit 80% at all times. I would say that your vendor needs to, at any point, actually needs to have this breakdown of where your failures are. Our vendor is Nuance, and so we get this report, so we know exactly what our failures are without doing our own Excel spreadsheet to be able to determine where our failures are, so we know where to work at with our facilities. So the severe sepsis takeaways for you is that the administrative contraindication is now 3 hours. There's no exclusion for that 6-hour window in case you are discharged or transferred. There is no exclusion for that. It doesn't look beyond that. And then the discharge disposition no longer can you put unable to determine. And abstraction will or can end at the first failure point. It's up to you to turn off that skip logic, and I really strongly consider that you do that. Your septic shock takeaways is once you answer yes to septic shock, and it's within that 6 hours of severe sepsis, then the algorithm is going to go to that administrative contraindication care, particularly for septic shock. So that would be your vasopressors, et cetera. And also if there is a directive for comfort care during that period of time for septic shock and discharge time. And if you have a reason for exclusion for septic shock, you will also not get credit for doing anything for severe sepsis. You just get excluded. There's also the next one on persistent sepsis algorithm issues. So again, you will fail for that repeat lactate if it goes beyond that 3 hour and your discharge expired, or on comfort measures past that 3 hour period. And in septic shock, we just talked about the issue of not getting credit for treatment of severe sepsis. Certainly you would give feedback to your clinicians about that, but not in the world of sepsis that's going to be reported, and that affects your denominator, of course. Then the septic shock presentation time versus fluids and persistent hypotension is still somewhat confusing. There's a lot of questions about that part of the algorithm and part of the bundle, and I think that's going to continue to be evolving as we go along. Also, if your protocol doesn't include a focus exam, you still have to answer the focus exam questions, and a lot of people are having difficulty, obviously, in that focus exam, meeting all that criteria that is needed to have a focused exam, and that has been challenging. I will say is one of our biggest challenges. And then we go on to the third international consensus definition. It's called Sepsis 3. So the European Society of Intensive Care Medicine, the Society of Critical Care Medicine in the United States, did create a task force to redefine sepsis. What's interesting is the surviving sepsis campaign members who's been diligently working for several years on surviving sepsis were not included in this task force. They did put out in February in JAMA what their consensus definition is. They changed the definition. There's no longer severe sepsis. It's just going to be sepsis. However, there is no consensus among other professional organizations, including your American College of ER Physicians and the American College of Chest Physicians. Because of that, there is not true consensus, and previously CMS has not adopted things unless there is consensus among all. National Quality Forum will also have to weigh in on this. But for sure, we don't believe that there will be any changes even in the January 1st, 2017. They have to actually provide, CMS has to actually provide any changes to the vendors 6 months in advance, and for them to have the programming time. So it just does not look like they've been able to get the consensus of what's happening with the changes here to be able to do anything for January. So the next thing you would be looking at is next July, and certainly we will all hear more as this evolves. So now let's talk about what do we actually do? How do we make improvements? What seems to be working throughout the country and is also our experience? I will tell you, we just merged with the Robert Wood Johnson Hospitals in New Jersey. It's been 2 months old. So what my experience I'm going to tell you about is Barnabas Health at this point in time. So that is the Barnabas Health. We call it Barnabas Health Legacy, but we are now one system and obviously integrating all of our approaches. But I'm going to give you our experience of this past year of how we have worked on our sepsis and what has worked. So our commitment truly was to reduce mortality. We also wanted to evaluate and improve our measures of care. So let's look at what a 3 and 6 hour bundle is. You all probably all know this by heart, but it's just a nice resource for you to bring to your work, put it up, bring it to your clinical professionals so they understand what it is. One of the things I found really good in the specification manual is what is the impact of compliance to bundles. So that has been truly, does these bundles help? Does it truly impact on the outcomes of mortality, which is the ultimate outcome, isn't it? So when you read the specifications manual, I know sometimes I glaze over when they talk about why they're doing this on that first page of the specs, but I think what you have here is some really great references to multiple studies that have shown that when you have compliance, then reductions of mortality has been noted and what those are. And I will tell you, our preliminary data, our higher performing hospitals are actually having less mortality rates. Again, all very preliminary, but we are seeing that, and hopefully it's following what the literature and research has found. So we actually started with a system approach. We had a steering committee, and in that steering committee, we actually were responsible for operationalizing data collection and feedback that was then each hospital had to have a similar structure. We created tools and structure on the system level, and then each hospital had to individualize that, realizing that each hospital has different resources and capacities in order to do certain things, but they had to meet the 3-hour bundle and follow certain parameters that were set up, and we'll share that with you. One of the things is that we are a Cerner shop. Our documentation, our EHR, is Cerner, and in Cerner they have what's called a St. John's Sepsis Alert. That St. John's Sepsis Alert is one that actually mines the data and looks for SIRS criteria to see if you meet SIRS criteria and if there was an organ dysfunction. So it's a little more specific than just using SIRS criteria. If we use just the SIRS criteria, we found that we would have thousands of alerts, and obviously no one can handle that many alerts. So their sepsis alert actually includes your SIRS criteria, meeting SIRS criteria, and an organ dysfunction such as the bilirubin, the creatinine, etc. So we started using that, looking at the electronic data. We had to validate it. We found it to be fairly sensitive in specificity. The one thing that the St. John's Sepsis Alert does not do, it does not identify a source of infection or potential infection. So that is the one component that alert does not do, and we have to depend on clinicians to evaluate that patient once the alert is fired, have to evaluate them to see if there really is a source of infection and document such, and then either go ahead with the treatment of sepsis, and if not, then we call it aborting the alert for that. So we have on-demand reports of all of the alerts used for monitoring, and we identified those potential sepsis patients, and we did 100% review as we were starting this process, because we really needed to understand why patients were alerting and how many of them were true sepsis and how many were related to alternate conditions, and we were able to change some of our alerts. Now, interestingly enough, we did have a lot of alerts, obviously, let's take for sickle cell, because they meet a lot of that SIRS criteria, obviously, and also an organ dysfunction just based on the what that disease is. But what we ended up doing, we had a request that we actually exclude all patients that had sickle cell. But what we did find out, though, is many times patients with sickle cell can also have an infection, but it's masked by the symptoms of sickle cell disease. And we actually had several cases in which we found that they had infection that people were not considering. So we were able to treat those patients and not have them go into that multi-system organ failure, which is the devastation that causes most of your mortalities. So our sepsis infrastructure was developed, and what we did is, I think probably a lot of people did the same thing, is our order sets and a pathway. Our order sets, one thing that we found that was easy to get is physician buy-in for the sepsis, because the Surviving Sepsis campaign, and it's very targeted, very focused, and based on literature, evidence-based guidelines. They can grasp it and get a hold of, yes, I get 3 hour, I get the 6 hour, I understand sepsis, we need to treat it aggressively. What has been a challenge, of course, is the challenge of IV fluids, and that's probably the biggest one that physicians trying to get that changing of practice has been the hugest challenge on the physician side and also from the nursing side for the IV fluids, but we'll continue that discussion. Order set path, so we broke it up to a 3 hour bundle, so we have since then, this past week, we decided to break it even further to have an order set just for diagnostics and an order for treatment for antibiotics and fluids, because often the sepsis alert would go off and they would look at the patient and say, well, I don't need to treat it yet because I'm not sure it's sepsis. Let's get blood cultures and let's get the lactate level, and we'll evaluate for a source of infection, decide if we need to go forward with the sepsis. fairly quickly. Obviously, you have 3 hours. But allowed to do that. And once the lactate comes back and it's confirmed that we do think we do have sepsis, then we need to do the treatment. So we've actually even created order sets that are even more specific to different parts of the care of the patient. We also have a specific site antibiotics. If we know that what site we think we have, that we have that specific site antibiotics. But our order set for antibiotics for the 3 hour is a huge, the broad spectrum antibiotic. We use cefepime, and if allergic, then we're using Levaquin. And we're saying if you suspect a gram positive, then you would use add vancomycin, because we know vancomycin is not considered a monotherapy for sepsis. There was a lot of good discussions. When we first started looking at sepsis, we had over 50 different antibiotics being used for our patients, and now we've been able to narrow that to use of a broad-spectrum antibiotic at the initial thing, and then understanding where that site is and then moving them to antibiotics that make sense for that site to treat that, because you don't want to keep them on broad-spectrum forever, because we know the C. diff is running rampant. We also created a sepsis progress note for the physicians and our rapid response team that responded to sepsis, so we have that templated so they would answer the questions. So all the elements that we need for the answering of the CMS measure was there. Process flow, which you'll see, of high level and code sepsis team response, and then our data, mortality. We have standardized mortality review, the 3 and 6 hour bundle compliance, and also daily feedback to the team. So whenever we have a sepsis alert and true sepsis, we analyze it and give it back to the team and say where they did succeed and where their failures were. We talked about the St. John Sepsis Alert policy. We did have a policy that was standardized, so this is all the work that the Sepsis Steering Committee did at the system level. But then the hospitals were able to and should individualize who makes up your code sepsis team based on, again, your capacity and your resources, what areas to respond to. Like some had the code sepsis team go to the ED, other places the ED felt that they wanted to do it themselves. And then also your hospitals and residents to respond, as in they would do for a code. So here is our generic algorithm, just to look at how did we map out who is responding at what point in time. So what is the role of early recognition, the RN, and the physician? Very important work to start thinking about the workflow and how is that going to look like in your facility based on the resources you have. And unfortunately, the way of the world is sometimes your day response may be different than your night response, but the important thing is to know what it is, and everyone knows what that process needs to be, so that way it is consistently done. Another type of algorithm is the actual response. Is it ED or non-ED patient, and how that would work to the point of yes, it's sepsis, or no, it is not sepsis, based on the alert and the evaluation that is done. So that is another tool that was provided, and again, the hospitals for us was able to individualize it, but again, the steering committee would look at that to make sure that the outcomes that we wanted were going to be there. We now have data collection and feedback, very extremely important. You cannot make improvements unless there's data collected, and also that feedback to that frontline staff, the clinicians, the one who's doing the work. So we did, on the system level, provide support. So we had daily calls when we were first rolling out the sepsis algorithms and protocols to see what the glitches were, what the responses were, if there's any information that needed to be further done. And then we did weekly calls with the hospital sepsis and Cerner teams to make sure that we were all making changes that needed to be done and understanding of what was happening. The daily report of alerts, the quality staff ordered the alert and then provided that feedback to those of the 3 and 6 hour bundle compliance. Also that focus review, and also I think it's extremely important to do reporting to multiple groups so everyone's engaged. So P&T, your antibiotic use, infection control, your ED and ICU, what that response is, nursing. So there's a lot of places that should be getting not daily feedback, but they should get in the reports on how we're doing and what our challenges are and barriers and successes. So this is extremely important to really close that loop and make sure everyone's engaged and have the information so that they can support that program. So lessons learned during our rollout. Well, We did recognize that there were a lot of alerts were fired after recognition. That was the good news, but we also found some cases that were not recognized. We did find that sepsis cases on med-surg, the alert went out before it was being identified, and that makes sense if you think about the workflow and the resources that are in med-surg versus ICU with intensivists or focused, very sick patients, and more of a focus, more over the time period of the day versus med-surg making rounds by physicians. We also started looking at the reasons for canceling the alerts, and we're having to adjust the parameters. We also found that the physicians were ordering components, not using the whole order sets, hence why we broke it down to diagnostic workup and treatments to try to put that into the way that a clinician may approach something. First you see if it is something, and then you treat it. So that's how we divided our order sets to see if it just would match the thought process of a clinician. We did find our repeat lactate. We did go into an ordering. Once a lactate was over 2, it's an automatic redraw. An automatic order is placed into the system to do a repeat lactate. First we chose 4 hours, and then we had to cinch that back down to 3 hours. We also are finding now still we have handoffs if the patient leaves the ED and goes to the med-surg or an ICU unit, that those repeats, because usually a ED draw, it does not change that they're now on the med-surg floor, so we're dealing with that now. So, as usual, when you think of PI, this is what happens, right? You get this information, and you have to find the next step. You find, this now is the new information that we need. So our continued challenges is probably the same as everywhere else, is the end of life, that documentation, that repeat focus exam. So we also provide to our ED, and I think this is of value for you to consider when you look at this. So in April, our ED 3-hour compliance, because that's what EDs can really do, is they're focusing on that 3-hour bundle compliance. You'll see that that's the second to last column, you will see that their ED 3-hour rate compliance is variable, but you see it's fairly high. But when you compare it to the CMS measure rate, which is all patients, right, not just your ED, and also the rate also includes 6-hour bundles and includes patients that may not have been in the ED, you see that the ED 3-hour compliance is much higher than the CMS measure rate. Of course, intuitively you would say that is true, but it's important to let the ED know how they're doing with that 3-hour bundle. And as you can see that we set our rate, our goal for this year for the ED 3-hour compliance is at 70 with a max of around 80. Hopefully they're going to achieve that and more. We see that a lot of our hospitals are reaching that goal because they're aggressively managing this with champions. And this right here is that components to be successful, and this comes from NAHQ. And it makes sense for any kind of PI project that you have. There has to be that vigilance throughout the organization, which of course is that providing that feedback, those reports to everyone does then get that buy-in engagement. To education champions, we've been most successful when we've had, of course, those physician engagement champions where someone else has that passion to really bring it through that organization. Then the tools, the responses, coordination, feedback to clinicians, everything we talked about is what you need to be successful. And I hope I provided to you how we were able to use those components and how we did this. So let's talk. Why are we doing this? Well, last year, we actually found that we had a 28 nurse from one of our facilities was presented to the ED. She had fever, tachycardia, elevated WCs, and high bands, but healthy otherwise. So they gave her 2 liters of fluids, gave her antibiotics, and told her to go home, right? Well, the next day she was admitted to another hospital with sepsis. So if we had that sepsis alert, we would have been more in tune to it looks like sepsis, and we need to actually admit her and watch her closely. So compared to what we found, 2 examples of patients that we actually had is a 59-year-old female, infected stump, med-to-med surge, a sepsis alert would trigger even though she had spiking of temperature and become hypotensive. Sometimes we just don't put all of those things together, and sometimes we don't notice that a drop of 40 millimeters of mercury is actually a hypertensive, even though they may have a normalish blood pressure. Our RT responded. her hemodynamics stabilized, and she was able to stay on the unit. She didn't keep deteriorating and had to be transferred to ICU. That is the key with this, along with the 31-year-old female. Again, received that IV fluid, stabilized, and she was admitted to med-surg and was able to be discharged 2 days later. These are the stories that we need to tell to get people to buy in why this is so important, that early recognition and treatment. And IV fluids, I tell you, we've had thousands now of patients that we've treated, well, not thousands, hundreds of patients that we've treated with IV fluids. And only one time did we overload a patient because it was sepsis versus cardiogenic, and it was not really quite clear. But that is the only time. So really, truly, we're finding that IV fluids are such a key component to treat these patients. So I thank you for listening, and I'll turn it back over to the moderator.
Great. Wonderful presentation, Deb. Thank you very much. Just a reminder to view any of NACU educational programs, including NACU Essentials, to visit nacu.org. And in conclusion, we just want to thank you, our sponsor today, Nuance. Thank you, everyone, and have a wonderful afternoon.
Bye.